Okay, thank you, Dr. Chandalia. You are my esteemed teacher and mentor. So thank you for your nice words. And I've chosen a slightly controversial topic because I have been uncomfortable about this for a while, especially since I started working with David Barker. So I'll start with what do we call gestational diabetes, and it's diabetes diagnosed during gestation. And the two questions I'm going to raise, are we sure it's only gestational? And do we really what is diabetes in pregnancy, the way we diagnose it? And this will open up a sort of avenue for discussion. If we look at the evolution of the concept of GDM, originally O'Sullivan and Mahan defined it as pregnancy glycemia, which predicted later diabetes in these women. So that had nothing to do with pregnancy. Pregnancy was an incident where they measured glucose. Subsequently, people realized that pregnancy glucose was associated with short-term maternal as well as fetal and neonatal outcomes. And very soon, from Chicago and from Pima Indian data, we had long-term maternal and offspring outcomes listed as a result of pregnancy diabetes. Various definitions have been given. For large part of our career, we have followed WHO definition, which peculiarly was just a transfer of non-pregnant values to pregnancy without any outcome measured. It's important to know that the transfer of susceptibility of diabetes and obesity from one to the next generation is both genetic and epigenetic. And that's where when people realize this, especially from work in Chicago, it started becoming very interesting. And therefore the crucial question is, are we able to prevent or not prevent the long-term outcomes which we ascribe to gestational diabetes as we define it today? As I said, I have been uncomfortable about this for a while. So in 2010, I wrote an invited editorial in Diabetes Care about fetal programming of diabetes. And the first point I raised was that is GDM a de novo diabetes of pregnancy, or is just part of something which we diagnose in pregnancy? I also discussed a number of other issues about life course trajectory of GDM, whether only glucose or other nutrients are important in fetal programming, whether insulin resistance was a mechanism which evolved to promote growth of babies in malnourished children and malnourished mothers. And finally, the important question whether our efforts to treat GDM reduced offspring diabetes, that is diabetes and obesity risk. The definition which we have used all along is based on the 5 symposia, the international NDDG workshops, where they said irrespective of whether or not insulin is used, if the condition or whether condition persists after pregnancy, we call it gestational diabetes. But they must have realized at that time, because it also said it does not exclude the possibility that the glucose intolerance may have antedated the pregnancy. It also became clear that many times what we call gestational diabetes turns out to be T1D or T2D in evolution, and that these both the pair of mother and baby are at a higher risk of diabetes, obesity, and cardiovascular disease. I have been in this for 30 years. Dr. Chandalia has been for longer periods. And I show in that cartoon that we have changed the goalpost quite frequently about what we call gestational diabetes, how do we treat it, what are the targets, and what are the short and long-term effects. So the question 1, is gestational diabetes gestational only? And this actually arose because I saw this publication in 1980 by Norbert Frankel, which was his Banting and Best sort of memorial lecture, where he showed gestational diabetes as arising somewhere in the middle of the pregnancy, while insulin-dependent diabetes arising early. And therefore, he postulated that the effect of gestational diabetes was only in the third trimester on the anthropometric and metabolic findings. Very soon, he realized that actually there was a permanent change in habitus caused by abnormal concentrations of nutrients during the period of intrauterine development, and he called it fuel-mediated teratogenesis to include long-term obesity and diabetes. Pima Indian study showed that children born to mothers who were diabetic when in pregnancy, their children had a much higher risk of diabetes compared to mothers who developed diabetes later on. So they called them pre-diabetic and assumed that they were genetically predisposed, but still their children were not obese, and therefore the idea of intrauterine programming of obesity arose as related to the maternal glucose concentration. I have spoken to Bill Noller, I have spoken to Peter Bennett, and they said majority of diabetic pregnancies in Pima Indians were actually pre-gestational. So we can't really call them gestational diabetes. And that is important to remember. Pat Catalano, who is the big name in studying the pregnancy metabolism, from before pregnancy, in early pregnancy and late pregnancy, his seminal work on 38 women who underwent a 3-day protocol 3 times. And what did he show? That whatever happened in pregnancy was already predictable in the pre-gravid state. So women who went on to get either gestational diabetes or other complications, all these factors were predictable in the glucose insulin metabolism before pregnancy. And therefore, he was the first one to point out that though we concentrate on pregnancies, things happen much before. This was a publication from the Californian group, which was studying actually whether the lipid profile of women who were diagnosed gestational diabetic during pregnancy was abnormal years before. So this is the Kaiser Permanente data, where they could find many hundreds of women who were diagnosed as GDM, but had a one blood test or a body checkup few years before in the Kaiser Permanente. So they were able to unearth this data from their records. And what were they able to show? That the women whom we call gestational diabetes had a higher family history of diabetes. Their pre-pregnancy BMI was higher. Not only that, their glucose was higher before pregnancy. Their cholesterol was higher, HOMA-IR index was higher, insulin concentrations were higher. So what do you call these women? They were either pre-diabetic, if we use some arbitrary cut point, but in other words, they had a diabetic phenotype many years before we diagnosed them in the 3rd trimester in pregnancy as GDM. And then, of course, came David Barker and said that what happens very early in life predicts your future risk of diabetes. In his study, he studied 65-year-old adults in Hertfordshire and showed that lower the birth weight, higher was the risk. Very soon a paper was published from Midlands where they showed that low birth weight was also a risk factor for diabetes in pregnancy. So what David Barker proposed was that type 2 diabetes, or we can say even GDM, is the outcome of the fetus and early infant having to be nutritionally thrifty. This was exactly opposite of what the American data was concentrating on, which was predominantly about fetal overnutrition in pregnancy related to maternal obesity and maternal diabetes. So for the first time, we realized that two aspects of nutrition, either undernutrition or overnutrition in pregnancy, can predispose you to higher rates of diabetes later in the life. And India is, of course, the capital of these two conditions. On one hand, we are now trying to become the world's capital of diabetes, which we traditionally assume to be an overnutrition condition, but we are an undoubted capital of the world for undernutrition. We have the largest number of low birth weight babies in the world, and we have the largest number of under 5 undernutrition. And David Barker told us that the mother-baby dyad was the answer to this discrepancy, that maternal undernutrition and fetal undernutrition is a risk factor for future diabetes. How do you analyze these in a prospective way? Because all the studies up till now were retrospective. David Barker had studied people whom he had studied at 65 years and found out their birth weight from the birth weight records of the hospital. So with his sort of mentorship, I set up the Pune Maternal Nutrition Study in 1993, which is one of the only preconceptional birth cohort in India. And now we are into 25th year of the follow-up. We studied mothers from before conception, studied them intensively during pregnancy, measured the baby by ultrasound in utero and by anthropometry at birth, and every 6 months after that birth for 18 years. And after that, we measure them every year. Every 6 years, we study their metabolism, their cardiovascular risk factors, their body composition, and not only children, but also their parents. When COVID struck, we had completed a follow-up of 24 years in almost a third of our cohort, and we will pick up when the COVID threat goes. This is one of the only studies in the world which has follow-up rates more than 90 to 95% even after 25 years. And we have a rich biobank started in 1990s and with a range of samples, and the number of tubes in my 24 freezers is more than 500,000. So a whole lot of things are possible to do on this biobank. The mothers were quite small and thin. They had a BMI of 18.1. Children were also small, 2.7 kg. Did the mothers have gestational diabetes? Their average fasting glucose was 72. Their 2-hour glucose was 75. And then we used the WHO 1985 criteria in 1993. Only 3 women had IGT. So very less gestational diabetes by the criteria which we used at that time. But as you all know, we described that these thin babies actually had higher fat than the English babies, and we rooted the concept of thin fat Indian babies. These babies had higher cord leptin concentration, higher cord insulin concentration, and lower adiponectin concentration compared to an average English baby, which was 3.5 kg. And we found that maternal micro and macronutrients both influence the fetal growth. And we have developed a story about B12 folate, but also about maternal glucose, lipids, and other nutrients. At 18-year follow-up, on which we have complete data, almost 50% of the children born in the cohort are underweight. That's a BMI less than 18.5. Only 5% are overweight and obese. 10% are stunted. What would you expect about glucose intolerance in these underweight children? That is where the whole story lies. 37% of these young individuals, despite being thin, had pre-diabetes. 37% of males and 18.5% of females. A massive prevalence of prediabetes in what we would otherwise call as an undernourished population. Now, how can we predict their glucose at 18 years? By studying their early life factors. That has been the focus of our analysis. You have heard me many times on this. What I am showing you here are their glucose curves in their life course, because we had measured their glucose at 6 years of age, at 12 years of age, and at 18 years of age. And subsequently, I will show you what happened in pregnancy. But just now we are looking at 18-year outcomes. If we divide the 18-year glucose into tertiles, you will see that these three tertiles have very faithfully tracked back right up to 6 years of age. So what we learned was that 18-year glucose is only a manifestation of what has happened from very early childhood. And subsequently, we put maternal glucose levels in this model and found that child's glucose at 18 years can be traced back to the mother's glucose, even though I told you that only 3 out of 800 women had impaired glucose tolerance. This is a remarkable finding. No other study in the world has such serial data. And this is even more remarkable. 6 years, if we divide the fasting glucose into quintiles, we can see that the highest quintile of 6 year has 3 times higher risk of being pre-diabetic at 18 years. If we put 12-year glucose, the highest quintile children have 6 times higher risk of being glucose intolerant at 18 years. In other words, if you were to measure their fasting glucose at 6 years and 12 years, you would be able to predict their chances of becoming pre-diabetic at 18 years. And the area under the curve for these rock curves was to the tune of 0.7 to 0.73. That's quite a remarkable finding. And this is a multivariate model. What was the contributors to child's glucose at 18 years, glucose intolerance? Being female was protective. So prevalence was twice as much in boys as in girls. Mother's overweight was again inversely related. In other words, obesity in the mother was not a risk factor, but lack of obesity was a risk factor. Mother's pregnancy glucose, even though it was in normal range by criteria which we used at that time, was a strong predictor of child's glucose at 18 years. If father's glucose was high, that was a predictor of glucose intolerance only in the daughters. So there is a parent of origin effect. And those who were short at birth and had smaller head circumference, but not birth weight, had higher risk of future diabetes. So now we have gone one step ahead than what David Barker told, and we are able to look at disproportionate growth in linear structure and head circumference as a predictor of future risk of prediabetes. And as I said, glucose at 6 and 12 years and body fat percent at 18 years were again risk factors. This is a remarkable equation of predicting who's going to go get prediabetes at 18 years from a life course measurement of risk factors. Then, of course, these girls are marrying. Many of them are marrying at a young age. And now, out of these 357 girls we have in our cohort, 185 have married and born children. We have a data on their glucose tolerance during pregnancy. And they are giving birth to F2 generation. We are now able to relate F0, F1, and F2 generations in a most remarkable way. So what happened? Between F1 and F0, a whole lot of social development and economic development has happened. The daughters are 5 centimeters taller than the mothers, and they have 1 mark BMI heavier than the mothers. But look at their glucose. The average glucose of F0 mothers fasting was 70. The average glucose of F1 girls is 80 milligrams percent, a whopping 10 milligram increase. And 2-hour glucose during glucose tolerance test has increased by 31 milligrams. A large increase in glucose in one generation in children who were born with an average birth weight of only 2.7 kg. And their children, interestingly, are now 250 grams heavier than what their mothers were. So we have this remarkable intergenerational story whereby we show that within one generation, there is a rapid rise in glucose during pregnancy. If we look at IADP-SG criteria, which we use today, 19 to 20% of these girls had gestational diabetes. As I told you, in their mothers, less than 1% had gestational diabetes by the WHO criteria. So what is now happening here? This up till now, I have shown you that what we measure in pregnancy is all determined and is very much present from not only early childhood, but also can be related to mother's glucose in the pregnancy. Remarkable finding. So to say that it's gestational is, I think, just putting the thing under the carpet, because it helps us to diagnose something and treat them. We have been doing it without really knowing what's happening. Now, is there a diabetic threshold in pregnancy? So do we know whom to call diabetic? This is the HAPO study, which is driving the current ideas and definitions of GDM. One look at this figure, which shows the association between the outcomes, the primary outcomes in HAPO study, which was large birth weight, LGA, cesarean section, neonatal hypoglycemia, and cord blood serum C-peptide, tells you that there is a continuous, graded, and monotonic association between mother's glucose and the outcome in the child. There is no threshold whereby you can see that at this point, the risk suddenly increases. In technical terms, there is no inflection point. This is a graded association. And now they have followed up the children at 10 to 14 years old, and various outcomes in the child, like fasting glucose, 1 hour glucose, 2 hour glucose, HbA1c, are again very graded, continuous, monotonic associations with maternal glucose in pregnancy. No threshold at all. But I think the current criteria were based on these findings, which were largely based on LGA, that means large for gestational age babies, which, as you know, is a problem in the Western world. Is it a problem in India? We will see that. And there was no diabetic threshold. Having found these findings, what they did was they applied a statistical arbitration and took a cut point that if the risk was 1.75 times more than the median, we will call it GDM. Whether we agree with that, we have to decide. But there is biology which tells us there is no threshold at all. What is happening is world is rapidly developing. India is also developing. I contributed to this Lancet series on double burden of malnutrition. And we wrote a lot of things there. Those of you are interested, read it. It was published over Christmas in 2019. And this figure has been included from the Pune studies. What we show here is the PMNS cohort, which is a rural cohort, Pune Children's Study, which is an urban cohort, and the Pune GDM cohort, which is the GDM women we treat in our clinic. What has happened? is that the maternal characteristics have progressively gone from BMI of 18.5 to 20 to 25. Birth weight has gone up from 2.7 to 2.8 kg to 2.9 kg. This is a continuous increase in a population which is developing on a background of multi-generational undernutrition. Are we worried about high glucose in pregnancy? Should we be worried about high glucose in pregnancy? We will see. I wrote my concerns just 2 months ago as a leader in American Journal of Clinical Nutrition. And I focused on fetal adiposity, which is what all this story is about. And I convincingly argue in that editorial based on our findings that it's a thrifty genotype which is aggravated by maternal obesity and diabetes, which is the problem with the world, but the interpretations can be different in different populations. It also suggests that world is moving from undernutrition to overnutrition, but even in overnutrition side, there is multiple micronutrient deficiencies, and women are short, indicating an intergenerational undernutrition which has kept them stunted. And there is a double burden of this undernutrition. This has been a thought in the thoughts of many leaders, and many of you will remember Lois Jovanovic, who was one of the real pioneers in the pregnancy diabetes. I was a great fan of her, visited her many times. You can see me here with Lois and Peter Bennett. I'm sorry, not Peter Bennett, Peter David. David Pettit, I'm sorry. And what she wrote in 2004 was a confessions of an old dog. And she said, never say never in medicine. For everyone interested, please read this. I'm just going to look at the last paragraph she wrote. I never imagined that the strategy to ignore maternal glucose in women who are carrying fetuses predisposed to intrauterine growth retardation and thus allow maternal hyperglycemia to remain untreated in order to encourage more accelerated fetal growth would be added to this list. So she also admitted that there was a misinterpretation in her studies. Finally, I'm going to say, are we doing good by treating GDM? This is a follow-up of a randomized controlled trial which was done in 8 centers in the US for treatment of GDM, and this is a follow-up of their children. In this trial, you will remember, which is called Landon's trial, the primary outcomes were not met, so trial was a failure. What was achieved was a 200-gram decrease in birth weight and large birth weight related outcomes, so cesarean section rates. Here now we are looking at the children when they are 10 to 14 years and concentrate on the upper table. None of the outcome in the children in the treated mothers are significantly different in the untreated mothers, namely BMI, waist circumference, impaired fasting glucose, elevated triglycerides, low HDL, hypertension. In other words, the way we diagnose GDM and treat it has not achieved what we have been saying it will do. This is again a data from my clinic that when we followed up 350 children from our GDM clinic, we found that children born to gestationally diabetic mothers who were intensively treated in pregnancy, 4% of them had diabetes, 5% of them had diabetes, 37% of them had pre-diabetes at an average age of 15 years, as opposed to 20% pre-diabetes in children born to mothers who did not have gestational diabetes. So again, a failure of treatment to reduce the risk in the babies. Pat Catalano also has been thinking, and we now actually believe that we are completely missing the early pregnancy window of programming. The periconceptional window of exposure to the baby is the most important epigenetic modulator. Baby's epigenome is reprogrammed within 48 to 72 hours of conception. If you are not able to control the environment at that time, the baby's fate is determined. So what he wrote was, therefore, achieving optimal metabolic health before a planned pregnancy may offer the best and not necessarily the easiest option to achieve a healthy pregnancy outcome, not only in short term, but possibly in long term as well. This was also said in 1990s by John Jarrett, a very reputed epidemiologist from England. He said gestational diabetes is no more than a special case of impaired glucose tolerance temporarily associated with pregnancy. So he was aware that these women very likely had high glucose before, and in the PMNS, we have for the first time showed that this can be traced back not only to early childhood, but also to her mother's glucose intolerance in pregnancy. Very noted embryologist, Louis Wolpert, said it's not birth, marriage, or death, but gastrulation, which is truly the most important time in your life. And this couldn't be more true if we apply it to the gestational diabetes. We need to come out of our idea that gestational diabetes can be diagnosed and treated in third trimester. We need to go from the clinic to the community, screen the young adolescents for their glucose, metabolic, and body composition health, and do something in them to prevent the programming of the fetus, which happens at the time of gastrulation. So I'm going to stop, thanking all the participants, my department staff, and my collaborators in India and abroad who have helped these studies. Thank you very much.